Okay, so let's talk about how these electrical signals actually travel through the heart. Well, first of all, the important part here are these other actual cells of the heart are different than other cells in our body, which allows them to send signals, not unlike skeletal muscles, but allows them to synchronize their signals a little bit differently. So for example, they are shorter, and then you'll see in this image, they have sort of this, they call it a branched or stair step kind of appearance. They have, you'll notice these sort of dashes or these clefts here. Those are intercalated discs. Those discs contain desmosomes that hold these cells together, as well as something that's really important, gap junctions. That allows the electrical signal to go across the skeletal muscle cell and simply flow right into the next one, into the next one, into the next one. So you can get this nice wave-like rhythm of electrical signal, and which is followed by a wave-like muscle contraction as well. Otherwise, they have the same actin and myosin as skeletal muscles, same sarcomere arrangement. That's why it's also striated muscle, similar to skeletal muscle. But again, it's these gap junctions in the intercalated discs and their branched shape that allows that smooth flow of electrical signal. And this will be really important, because when you think about it, that contraction in the atria needs to start from the top and kind of squeeze down so things can move down into the ventricles. And from the ventricles, the contraction has to actually start at the tip of the heart and kind of push up and out the pulmonary valve in the aorta. So it's not a side-to-side contraction, but it's a top down in the atria and then a bottom up from the ventricles. These muscle fibers are also autorhythmic, meaning that they don't actually have to have a nerve stimulating them. They will contract by themselves, so they are self-excitable. So they have their own natural pacemaker and conduction system. So you've probably have seen the movies where someone's heart is plucked out of their chest and it keeps beating. That is actually true. That can happen. It'll stay beating as long as it's getting the right nutrients and oxygen. It will continue to do that. So let's talk a little bit more specifically about the signal and the path of that signal. So there's a node, there's a particular cluster of cells in the right atria called the sinoatrial node. That's where the signal conduction starts. And you'll notice these arrows and how they travel. The signal doesn't just go in any old direction, it goes along specific pathways, and part of that is going to be due to that fibrous skeleton. Remember, we mentioned that in the other video. That fibrous skeleton acts as an insulator, so it limits the direction that the electrical signals can go, which is, again, important so that we have this nice wave-like contraction that follows. So the signal starts in the sinoatrial node. As you can see, it will flow down the right atrium over to the left atrium. It will then travel to something called the atrioventricular node, which is sort of getting closer to the midline of the heart. The electrical signal will then go down something called the atrioventricular bundle. This bundle of His is the old name for it. So the atrioventricular bundle, in this septum, this myocardial septum or interventricular septum, that those branches divide. So there's a left and right bundle branch in this myocardial septum, and then they will simply, on the left side, they'll simply curve toward the left and up, and on the right to the right and up. Right, so you can see how the signal goes this way, so that the contraction then follows that down. It goes down this way and then back up, so the contraction is going to start here from the bottom and go up. So again, that's what's going to allow the heart to actually pump blood up and out the heart, not just kind of to the sides. So that SA node acts as a natural pacemaker. And honestly, I don't know why I can never remember to fix this. I'm going to fix this right now. It does not initiate 100 times per second. It's per minute. So we're just going to fix that right now. The SA node acts as a natural pacemaker. It's faster than the autorhythmic fibers, so that it, again, sets a slightly faster pace to the heart. If left alone, it would have the heart beating at a standard rate of 100 times a minute. Okay. Your autonomic nervous system establishes the actual, well, I should say modifies the timing of your heartbeat. So basically, parasympathetic nervous system is going to come in. So as you're sitting here listening to this video, hopefully you're not particularly stressed out. So your resting heart rate is closer to about 70 beats per minute. Again, that's your parasympathetic nervous system basically slowing down the SA node. Now, if you all of a sudden got up and had to run out of the room, or something else might have happened that stresses you out, your heart rate will increase. Again, that's the autonomic nervous system, but now it's the sympathetic branch that will stimulate your heart to beat faster as well as stronger. Okay. So again, it's not that it establishes the rhythm. That's the SA node, is your natural pacemaker. However, it will modify that rhythm depending on your circumstances, whether you're at rest or in a fight or flight kind of situation. All right, so let's talk a little bit about action potential. So how does that signal actually occur? If you remember back to 201, so this is your action potential in 201 that you learned about in nerves. So just a quick review, right? On the y-axis, we have the membrane potential in millivolts. On the x-axis, we have time in milliseconds. So we have a resting membrane potential and then a threshold amount of negative 55 millivolts. Some stimulus comes in, it takes us to that threshold, right? If you remember, sodium channels are going to open, which causes depolarization to occur at about plus 30 millivolts. The sodium channels close, potassium channels open, and then there's repolarization that is occurring. There's a short hyperpolarization phase before we return to our resting membrane potential. Okay, so that is for our neurons. It's just a little quick review, because the heart is going to be very similar, but a little bit different. Because when you think about it, an action potential in a neuron is going to be a very quick, let's just send a signal, let's just send another signal. We want very fast ability to have fast, like twitch muscles even. In the heart, we don't want a twitchy heart. That is bad. We want a signal, strong muscle contraction, and then relaxation, right? We don't want flutters occurring in the heart. That's not going to help us push blood. So again, we're going to have the same sodium channel, same voltage-gated potassium channels, the same idea of a threshold needing to be reached, but with one important exception. So we have a slightly more negative resting membrane potential, so we're at negative 90 millivolts. However, we're going to have a threshold that is hit. We're going to have a rapid depolarization due to our positively charged sodium ions. But what you'll notice here is instead of that rapid repolarization, we have what's known as a plateau. So we have a third ion now that's coming into play, and that's going to be calcium. So calcium is going to be flowing in at the same time that potassium is flowing out. So there's going to be, because we're gaining a positive charge at the same time as we're losing a positive charge, our net membrane potential is going to kind of stay level for a little while. And this is not a super long amount of time. You can see this, it's like 0.3 seconds before repolarization can actually occur, before those calcium channels close, and now the loss of the potassium is greater, and therefore we are going more negative. This period is also coincides with what's known as a refractory period. So basically what a refractory period is that no matter how much of a signal comes in, it won't cause another action potential to occur. And again, this is going to be really important, because if you remember back to like skeletal muscles, we could have tetanus of our muscles where they just kind of clench and they don't like relax. We don't want that in our hearts ever to happen. So we by having these calcium channels and this absolute refractory period of a long absolute refractory period, it prevents the heart muscle from just kind of clenching up like in a tetanus or like in a Charlie horse. That would be very, very bad if you suddenly had a heart cramp. So this prevents that from occurring. Okay, so that's all great, but this doesn't look anything like an EKG, right? That's because an EKG is going to be a sum of all the electrical signals, not just one single cardiac muscle fiber. So it's going to look a little different. Well, let's talk about that. There are different types of EKGs. There's a 5-lead, there's a 12-lead, and don't worry about memorizing either one of these two. These are just here for your information as you go into nursing or a healthcare field. They'll have you learn exactly where all of these are and where you would put them. The more leads you have, the more accurate the reading's going to be. Just sometimes it may just be a matter of ease, or maybe the patient has other, underlying health issues that would prevent you from doing one sort of setup versus another. Okay, that being said, let's take a look at what an EKG actually looks like. So again, this is just a composite recording of all the action potentials by all the heart muscle fibers. So it's not going to look like that depolarization, repolarization plateau that we just saw. What the machine does is it compares the tracings from the different leads with one another, and then that's how we get this readout. Our three main waves are P wave, QRS complex or QRS wave, and then this T wave. And what you'll hopefully notice is we'll have the electrical signal, which is followed shortly after by the actual muscle contraction. So we'll have the signal and then the contraction occurs. Okay, so again, you have to have the signal before the muscle can react. Okay, so let's talk about how EKG waves or ECG waves correspond to the actual actions going on in the heart. Okay, so again, quick reminder, systole is just contraction, diastole is just relaxation. Okay, so we have an action potential that's starting in that SA node. Well, that P wave appears. After that, we just saw a second ago, now we have atrial contraction or atrial systole. Either term is fine. That action potential then enters the AV bundle, and then it will quickly go out and over the ventricles. This is going to be the QRS complex. At the same time, atrial repolarization is occurring, but we do not see that in the EKG, simply because this QRS complex is so large. It masks the signal for atrial repolarization. Again, shortly after we see that QRS complex, the contraction of the ventricles occurs, or ventricular systole, and this contraction is going to continue during that ST segment. After that, we have repolarization of the ventricle muscle fibers. That's that T wave, and then the ventricles relax. So if we kind of put all of that together in an image of the heart and then an EKG, so we have that SA node, P wave occurring, atria contract, then we have the QRS, and the ventricles contract, and then here we have the T wave, the ventricles are relaxing, and here we start that cycle all over again. So hopefully that makes sense to you. Now, what you will find is that we measure these, and you'll see this in lab as well. We measure how long a P wave lasts, the segment between the P and the R, between the R and the R, between the S and the T, between a whole bunch of these different waves, as well as the amplitude of these waves. You may ask yourself, well, why? And you don't need to know like all the specifics or anything like that, but I just want you to understand why we care about these things. So if we see an abnormality in the P wave, it can indicate a left atrial enlargement, hypertension, or atrial fibrosis. So basically the muscles turning into fibers, so loss of muscle. An abnormal P wave is linked to atrial fibrillation and even stroke. So obviously we care. A QRS complex that may be wide is a hallmark of a bundle branch block, meaning right here there's some sort of scar tissue that is preventing the electrical signal from going quickly to where it needs to go, and which means that the peak widens. An abnormal T wave may indicate an ion imbalance, such as too low or too high potassium levels, too little calcium, or too little magnesium. Okay, so let me just show you what potassium abnormalities can look like and how that shows up on an EKG. So again, so here's our normal EKG, and here's too low of potassium levels. So you'll notice this PR interval is way too long. There's this weird shallow T, and then all of a sudden we see this U wave that oftentimes is absent in most people's EKGs. If you have high levels of potassium, and you'll notice here the amounts, so here it's 6 to 7 millimolars of potassium, 7 to 8, 8 to 9, and then greater than. So even with just a little bit of an elevated levels of potassium, we see a really elevated T wave, like almost as big as that QRS complex. That, again, can be very dangerous. If it gets even higher, we may see a prolonged PR along with this, which is different from what we saw here. Even more, that QRS is showing, it's much wider than this kind of shallow, very peak. Again, that T wave is now about the same height. The ST is just what's known as depressed. And then if it's too large, we see what's called the sine wave, these waves that are just almost the same size. So all of these would indicate hyperkalemia. And again, that could be deadly because now your heart muscle is not getting the correct signals, so it's not contracting correctly, so it's not sending blood to the organs like it needs to. One of the other things we can tell in using EKGs is whether or not there's something called an axis deviation. So what an electrical axis is, it's the average direction of ventricular depolarization. So basically it's letting you know where the tip or the apex of the heart is pointing. So with an axis deviation, if we see a left axis deviation, this can also indicate a left bundle branch block, basically an enlargement of the left ventricle, and possibly an inferior infarction, so like death of some of the cardiac muscle tissue. A right axis deviation may indicate right ventricular hypertrophy, hypertension, left ventricular infarction, so any of those things that might deviate it to the right, where we would see greater electrical signal in that area. An extreme axis deviation is super rare. Usually it's a mistake in electrode placement. If it's not, this is deadly. Like if this is showing up on an EKG, that's the exact opposite direction that it should be going in. So this usually means a very severe heart attack. Okay, so hopefully the electrical signals going through the heart make sense to you. If you have any questions, please let me know.